We are ready. It's 8 o'clock. Good morning, everybody. Before we start, I'd like to repeat something that I've said before, which is the difference between studying in a university and studying in a grade school. It is not a matter of memorizing a small number of issues and then dumping it on the exam paper or in the electric exam. It is not that I should give you something that I ask you to memorize and then I will ask you about them later on. University is for every student to try to get the information for himself. What is the role of these lectures? The role of these lectures are two. Number one is to explain things that are difficult to explain when you are reading it in a reference. And number two is to put the things in the right perspective. As you can see, I'm approaching all of these issues or diseases not as a disease, but as a complaint that someone will come to you, because this is a natural way. If you are a physician, someone will come to you and say, I'm dizzy. What is the problem? Nobody will come to you and say that I have Meniere's disease and what are you going to do about Meniere's disease? The patient does not come with a diagnosis, he comes with a complaint. I'm approaching things from a complaint and putting it in a differential diagnosis type of, that's number one. Number two, the role of the universities is to teach you how to get information for yourself, how to teach yourself, and also is to develop new information. That is what is called research. I was surprised that I received requests that they want to trim the copies of the lectures that I gave in order to emphasize about the things that I'm going to ask about. I'm not going to ask you about something that you did not hear, everything you should be hearing. You take these lectures as a guide for learning, and you go to the references and you learn, you get the information for yourself. It's not that I'm going to give you a summary, what I'm going to ask you about, and then I have more respect for you as a university student than your trying to convince me that you are a grade school student. I think that I've said enough here. We're going to talk today about neurodegenerative disease and about dizziness. Now, what is the meaning of degenerative? Degenerative in Arabic means tanakus. Arabic is a very fine and very specific language. Tanakus comes from the word nakasa, and nakasa means to go down in a vertical position. That's why when they say nakasa al-alam, that means that instead of raising it up, they bring it down to half staff and so on. When there is a national mourning, some countries will bring their flags down. While nakasa is to turn around in the horizontal, not in the vertical position. That's why we say nakasa ala aqibayhi. That means he turned around in the opposite direction. And then nakatha is for things that are verbal. You give your word and then you give your promise and then you nakatha. So neurodegenerative disease هي الأمراض التنكسية that affects the central nervous system and cause it to go down in its structure. وَمَنْ نُعَمِّرْهُ نُنَكِّسُهُ فِي الْخَلْقِ. That's why it is common in the older age group. Now, we go to what are the general characteristics of neurodegenerative diseases. They are classified mainly in two main groups: those that affect the cognition, affects the thinking, and those that affect the motor function. Now, the first characteristic is that there is spontaneous progressive degeneration of neurons. They lose their activity gradually, and they lose their activity spontaneously, not because of an external effect. And it affects the groups of neurons that have functional relationship or some systems. That's why when we talk about Parkinson's disease, we talk about the substantia nigra and its connection to the basal ganglia as the dopamine system affected mainly. So it's groups of neuron with functional relationship. And the pattern of loss is selective, affecting one or more groups of neuron and leaving the others intact. And there are different diseases that involve specific regions in the system, in the brain or in the spinal cord, or both of them. What happens pathologically, that there is a protein aggregates that is resistant to normal cellular mechanism for degradation. Now, the cells are not fixed structures. The cells always undergo change in their composition. The proteins are always formed, and then the old proteins are always degraded. That means that they are dissolved to peptides, and then they are taken as a building blocks to make new proteins. And there is a system that is called the ubiquitin proteasome system that takes the proteins that have finished their job and to replace and to break them down and to replace them with new proteins that are synthesized under the guidance of the DNA in the nucleus. The basis of aggregation of these abnormal protein aggregates, that there is a subtle imbalance between protein synthesis and the clearance of these proteins. Or there might be an inherited mutation that disrupts the pathway involved in processing the clearance of these proteins, and that deficiency slowly lets these abnormal proteins aggregate in the cells and cause the demise of the cells. And there are some mutations that alter the protein conformation, which is the proteins do their job according to their shape. So they have to be shaped in a special way if they are an enzyme, or if they are something that causes contraction of a muscle, and so on. They have to be conformed in a certain way. If the shape changes, they stop performing. And the aggregated proteins are generally cytotoxic, but the mechanism may be different in different diseases. And there are factors that are combined: genetic predisposition, exposure to environmental toxins, oxidative stress that happens always in the cells when the cells takes the oxygen, and then it may generate reactive oxygen species or radicals, which may be toxic to the cell, and also aging. The phenotype of the neurodegenerative disease determined by the distribution of these aggregates of proteins more than the nature, because the nature of the protein, because we can see different diseases or different phenotypes that have the same aggregate of protein inside the cells, but they will be different system cells. Many of these proteins are capable of spreading to nearby healthy neurons, like prions. And we're going to talk about prions. What are prions? They are considered, they behave like infective agents, although they are proteins that are essential for the cells. But they don't spread from person to person in general. Alzheimer's disease is not infectious. and they may cause activation of the innate immune system. Now we go to general considerations of symptoms. There is the diseases that affect the cortex, and they manifest by change in cognition, in memory, personality, and so on. These, we call them dementia. There are those that affect the basal ganglia, and they manifest as a movement disorder. The prototype of that is Parkinson's disease. There are these degeneration that affect the motor neurons, either in the cerebral cortex or in the anterior horn cells and the spinal cord, and they may present as motor weakness. And finally, if degeneration happens in the cerebellum, it causes ataxia. So the motor disorders may affect the neurotransmitter that is responsible for the smoothness of the movement, and if dopamine is deficient, we call that Parkinson's disease. If the motor disorder affecting the cerebellum, it will cause ataxia. If it's affecting the motor neuron, we call that amyotrophic lateral sclerosis. While the dementias may have a degenerative cause, or it may have other causes that happen in old age, like cerebrovascular disease, which reduces the blood supply to the brain cells, or nutritional deficiency, like the lack of vitamin B1 thiamine, which leads to Wernicke-Korsakoff, which affects alcoholics. Degeneration of the CNS, we have been talking about degeneration like Pick's disease, Huntington's disease, or infections such as Creutzfeldt-Jakob or HIV. And finally, the prototype of dementia is Alzheimer's disease. With aging, there is a reduction in the chemical transmitters of the brain. And there are two major chemical transmitters. These are the catecholamines, which include the dopamine and norepinephrine and so on. When they are reduced, their formation is reduced by age, then it causes slow movement and slow reflexes. But when there is higher loss of that, what happens, or they exceed a certain threshold, then there is pathological slowing, and that leads to Parkinson's disease. While the other transmitter that we will talk about is acetylcholine. Acetylcholine is the main transmitter related to memory, and it is in the hippocampus. And if the production of this neurotransmitter is slowing, it will cause benign senescent forgetfulness. Older people may be more prone to forget a few things. But if it exceeds again this threshold, it will cause dementia like the Alzheimer type dementia. Alzheimer type is mainly a dementia that affects memory. Now, these are the features of the major neurodegenerative disease. What are the protein inclusions and what are the clinical patterns? Dementia in Alzheimer's disease, there are two proteins that accumulate in the brain. Amyloid beta, which cause the plaques, and tau, which cause the tangles. There is the frontotemporal lobar degeneration, which causes behavioral changes, language abnormalities, and so on. It will have tau like in Alzheimer's disease, but it also was found to have a certain protein that is called TDP43 and rarely some others. In Parkinson's disease, the features are hypokinesia and difficulty with movements, and the cells will have alpha-synuclein and tau. You find out that, as I mentioned before, the nature of the protein does not necessarily have an impact on the clinical pattern, because the same protein may be accumulated in the different cells and cause different pattern. Huntington's disease causes chorea and causes dementia, and the accumulation of what is called Huntingtin, which is a polyglutamine repeat expansion. Spinocerebellar ataxia, various proteins such as polyglutamine repeat expansion, such as what happens in inherited ataxia, Friedreich's, and the like. Amyotrophic lateral sclerosis causes weakness, and the protein inclusions are in superoxide dismutase 1 and TDP43. TDP43 is common between amyotrophic lateral sclerosis and frontotemporal lobe dementia, which we will also expand on later on. First of all, let's talk about dementias. It's a syndrome of progressive deterioration in cognition, and it is defined as the deterioration is beyond what might be expected for normal aging. And it is severe enough to interfere with normal daily activities and social relationship of the patient. It affects memory, attention, thinking, orientation, comprehension, calculations, all of these domains of thinking, language, problem solving, and it is accompanied by also deterioration in emotional control and social behavior. However, very, very important that it doesn't affect consciousness. Remember, when we talked about the consciousness and we talked about coma and so on, and delirium and the stupor and so on, it doesn't happen with dementia. The person is awake, alert, but the content is lacking. What are the normal functional changes due to aging? Reaction times become less. Also, proprioception becomes less. That's why it affects their balance. Elderly people are more prone to fall, and their posture as well. They assume a different posture. Thermoregulation may be affected. They may develop either hypothermia or hyperthermia, depending on the outside temperature. There might be sleep disorders. Insomnia is common in older individuals. And special senses are important because, as we know, older individuals may have decreased vision, decreased hearing, and decreased smell, and so on. Minimal cognitive impairment. Minimal cognitive impairment is a condition where there is memory and some other cognitive impairments, but it doesn't affect the social functioning or the daily living. So the person is still able to function normally, and some patients may progress to Alzheimer's disease, but others may remain stable or may revert to normal, indicating that there are some external causes for minimal cognitive impairment. And the cognitive dysfunction of short duration, which happens if you put an elderly patient in the hospital, he may get confused and agitated, and we call that delirium or acute confusional state. How do we assess minimal cognitive impairment? We do a mental status examination. We do sensory and motor deficits to look for potential cause of or exacerbating factors, and we try to see what the cause has happened. It may be a deficiency of a vitamin, it may be an external cause such as alcohol, and so on. The common causes for minimal cognitive impairment is cerebrovascular disease, trauma, sleep disturbance. An elderly person, if he loses sleep for a day or two, he may get confused. Chronic psychological stress, depression, and drugs or alcohol. Metabolic and endocrine, common in elderly people, such as hypothyroidism or vitamin B12 deficiency. Alzheimer's disease may be manifested early as minimal cognitive impairment, and then the patient will progress into frank Alzheimer's disease. Parkinson's disease may cause some minimal cognitive impairment. Frontotemporal degeneration and HIV infection because it causes problems within the central nervous system. The dementias, we divide them into primary dementia and secondary dementia. Primary, the list Alzheimer, Pick's, Creutzfeldt, and so on. Secondary dementia, secondary to multi-infarct, to normal pressure hydrocephalus, to drug. These secondary dementias are something that we would like to find as a cause for the patient because they can be reversible. Some of the reversible causes are liver disease, renal failure, hyperlipidemia, electrolyte imbalance, hypothyroid, and so on. Dementia also can be divided into cortical dementia, such as Alzheimer's and Pick's disease, and the salient features for that are aphasia, amnesia, apraxia. Apraxia means inability to do the sequence of learned acts, like the patient may not be able to know how to hold a key, put it in the keyhole and turn it around. Agnosia, and may lead to empty speech. While subcortical dementia affecting the deeper structures in the brain, there are the progressive supranuclear palsy, Huntington's, Parkinson, some metabolic diseases, and the normal pressure hydrocephalus. They are manifested by slow cognition, forgetfulness, deterioration of intellect, some affective disturbance, emotional disturbance, movement disorder as in Parkinson, and more of dysarthria, which is difficulty in executing speech. Alzheimer is the chronic progressive degenerative disease. 60% of dementias occurring in elderly patients over 65 is due to Alzheimer's disease. And Alzheimer is an amnesic type of dementia, but also affects judgment and visuospatial perception. That's why if you ask the patient to copy a shape, he may not be able to copy it right. And there is change in personality, that becomes more aggressive or more irritable. And with increasing cognitive impairment, there is some physical deterioration, and finally immobility that leads to death from complications. Two famous public figures that were affected by Alzheimer's disease. Clinical features, initially there is forgetfulness, as I mentioned. It's an amnesic type of dementia, but with progression, there is difficulty with language, mathematical skills, and loss of learned motor skills that leads to apraxia. And in the final stage, the patient may become incontinent, mute, and unable to walk. Progression is slow. However, it doesn't stop, and the symptomatic course may run for over 10 years, and the terminal events usually is an infection such as pneumonia. The risk factors are aging, head trauma, exposure to ingestion of metals such as aluminum, family history. It is lower in Caucasians than in other races. The female gender may be more exposed to it. Depression in a patient over 65, and patients who are born with Down syndrome, they accumulate amyloid beta in their brains at a younger age. That's why if a Down syndrome patient reaches the age of 40, frequently they develop Alzheimer's disease. But the majority are sporadic, and the genetic factors in about only 10% of patients. Usually it's earlier onset. Grossly, what we see, this is a healthy brain, and this is a severe Alzheimer's disease. As we can see, there is shrinkage, there is increased size of ventricles, there is opening of the sulci because of loss of parenchymal size. What are the structural changes? The two major structural changes are neurofibrillary tangles and senile or neuritic plaques. There is increased beta amyloid and significantly increased vascular degeneration as a contributor to the morbidity in this disorder. And from neurotransmitter viewpoint, there is loss of acetylcholine. That's the major neurotransmitter that is deficient in Alzheimer's, but norepinephrine and dopamine and serotonin to a much less extent. These are normal neurons, as we can see, and this is Alzheimer's disease. In Alzheimer's disease, we have amyloid plaques. Amyloid accumulates extracellularly, not inside the neurons, and mainly it affects the areas where there are synapses, and it impairs the synapses, which are the important connection between the cells. That's why you lose the connection between the cells, you lose the transfer of information. Neurofibrillary tangles, on the other hand, they are fibrillary structures inside the neuron, and they impair the function of the neuron proper. These are the diffuse plaques, and they are mainly in the superficial portions of the cerebral and cerebellar cortex. That's where the neurons are located. The neurofibrillary tangle, on the other hand, this is how they look under the electron microscopy. It is paired helical filaments, as we can see them here, and they are more indicator of the progression of the disease because they kill the cells. Now, when we talk about diagnosis of Alzheimer's disease, if there is sudden onset, it is not Alzheimer's disease. If there is focal neurological findings such as hemiparesis or sensory loss, it is not Alzheimer's disease. If there are seizures or gait disturbance early in the course of the disease, it's not probable to be Alzheimer's disease. The progression of Alzheimer's disease starts in the what we call the entorhinal cortex. And then it spreads to the mesial temporal structures, such as the hippocampus. And this is the one that is responsible for memory deficit. And then it becomes more generalized and affects the whole brain. Over here, we can see a coronal section on MRI that shows the atrophy of the hippocampus and the resultant increase in the size of the anterior temporal horn. It is not unusual to find asymmetrical involvement. That's why we see the hippocampus here less involved than this one, less involved with atrophy. So we have some biomarkers that allows us to suspect and diagnose Alzheimer's disease with a good level of certainty. We try to get amyloid beta 42 in the CSF, as well as tau in the CSF. By measuring them, we can tell if this patient has Alzheimer's disease. The measurement of hippocampal volume, as we have seen in the previous slide, and if we do the FDG, fluorinated FDG PET scan. What is FDG? It's fluorinated dextroglucose, deoxyglucose. Fluorinated deoxyglucose, it's linked with a positron emitting radionuclide. And when it is injected, it goes to the cells that are active and they are consuming glucose. It behaves like glucose. Then when we take a scan that detects the positrons that are emitted from this compound, we see where there are areas of high glucose consumption or low glucose consumption, and then we find that there is hypometabolism in the temporoparietal regions that is typical for Alzheimer's disease. If all the three markers are positive, even in a patient with minimal cognitive impairment, most likely he will progress into Alzheimer's disease. However, the number of neurofibrillary tangles pathologically determined by a biopsy is a better marker for the degree of dementia, and the best correlation is with the loss of synapses, as what happens when we deposit amyloid in the synapses. Now, let's look at the time course for now patients with Alzheimer's disease may have CSF amyloid beta even way before mild cognitive impairment happens. CSF tau comes next, even before mild cognitive impairment. MRI atrophy may start at the time of mild cognitive impairment or slightly before, but it is not quite recognizable. When there is a start of cognitive symptoms, of course, this is the curve of clinical pattern, starts with MCI and then goes on to dementia. Vascular dementia, on the other hand, it is caused by decreased blood supply to the brain and thereby decreased viability of the cells, and the risk factors include age, hypertension, diabetes, and hyperlipidemia, and these factors are sometimes very commonly combined in the elderly, and it is the second most common dementia after Alzheimer's disease, but its incidence drops after the age of 75, unlike Alzheimer's disease, simply because if the person have escaped that age without vascular dementia, then he doesn't have much of these risk factors and he is not going to develop them later on. About 87% of those who were during life diagnosed as vascular dementia also had accompanied Alzheimer's disease. Alzheimer's disease is very common in the elderly. However, from clinical standpoint, stepwise progression is characteristic. The patient does not have a slow, gradual deterioration. He may at one time lose a certain function, then stabilize, then another time lose another function, and then stabilize. And that is what we call multi-infarct dementia. And it happens in men more than women. And there is history of the risk factors that we mentioned, and it is frequently associated with hypertension. Usually there is a sudden onset and focal signs and stepwise decline. A condition that is usually confused with dementia, but it is treatable, and we would like, although it is not common, but if it is found, it is reversible. Normal pressure hydrocephalus. The person may look apathetic. His speech will be abbreviated. He has a stooped posture similar to Parkinsonians, but he develops incontinence and he walks with small steps. And usually they say that there is a 3 W's. The person is wet because of incontinence. He walks wobbly because of the magnetic gait that is accompanying that. And he has a weird mentality because of the dementia. So weird, wet, and wobbly. The diagnosis is by CT scan or MRI. We see that the ventricles are distended, compressing brain tissue out of proportion of atrophy in the surface of the brain. And the treatment is by shunting, but the treatment has its complications. If it is over shunting, it may cause subdural bleeding as it collapses the surface of the brain. Pick's disease is a rare disease. It is autosomal dominant with high penetrance, and it has focal signs and early behavioral problems. And usually they say Pick's disease picks certain lobes and causes focal symptoms. Frontotemporal lobar degeneration may overlap with Pick's disease, And it's a group of disorders that share the clinical features of progressive deterioration of language and change in personality because of atrophy in the temporal and... Pardon? There is noise. If you please mute your microphone. Mute your microphone. In the temporal lobe, language problem is frequently the presenting complaint, but there are symptoms of memory disturbance which can assist in the separation from Alzheimer's disease. Now we come to prions. Prions are characterized by pathology with the spongiform encephalopathy. Why do they call it spongiform encephalopathy? Because when you do the autopsy or biopsy of the cortex, you find that there are several vacuolations, small vacuolations in the parenchyma. There is characteristically no inflammatory reaction, so it's not an inflammation of the brain. And there is no immune response. There are no lymphocytes. The neuropathology, as I mentioned, spongiform changes, but there might be also some reactive gliosis and neuronal loss by apoptosis, and there might be some amyloid plaques. Prion disease in humans, there is a Kuru that happens in some Pacific islands because of the cannibalism that they do in there. There's the Creutzfeldt-Jakob disease and the variant Creutzfeldt-Jakob disease and a rare Gerstmann-Straussler-Scheinker syndrome and fatal familial insomnia. Now, in animals, there are some prions disease. Scrapie affects the sheep. Bovine spongiform encephalopathy that had a big publicity when it affected cattle in England and some other areas in Europe and caused great scare in the latter part of the last century, and the chronic wasting disease that happens in elks. So what is prion? Prion protein, which is referred to as PRPC, is a normal component of the cell, normal protein in the cell. There might be some inherited deficit in the composition of this prion protein C that leads to it misconforming. It changes its external shape, and that's when it becomes called prion protein SC, SC for Scrapie. So there is abnormal conformation, but this abnormal conformation will serve as a template where it may take another molecule of the same protein and imprint it with the same shape, so it spreads, it proliferates, it increases itself, and at the end there are a lot of prion protein SC that leads to spongiform encephalopathy. So it just prints itself, whether it is acquired because of inherited prion disease or whether it is acquired from external, such as what happens with the variant Creutzfeldt-Jakob. Creutzfeldt-Jakob disease occurs worldwide, and they present with rapid dementia. It is very important that it is a rapid progressive dementia, unlike Alzheimer's disease, which is very slowly progressive, and may lead later on to myoclonus, tremors, rigidity, and they lead to akinetic mutism because of the general degeneration of the cortex. And over 50% die within 6 months. So that's how rapid it is. The clinical course is highly suggestive, and there are some biomarkers. EEG, there is diagnostic picture in 75% where we have a periodic discharges on the EEG. CSF test, sometimes it is helpful. It has a protein from degeneration of cells called protein 1433, and genetic studies for those who have the genetic mutation. Neuropathology is required for confirmation. Cerebral MRI demonstrates the hyper intensity in the region of basal ganglia that we are going to show later. So if you have that MRI finding with rapidly progressive dementia and myoclonus, then it is Creutzfeldt-Jakob disease. This is the hyper intensity in the basal ganglia, and on T2 it is hypo intense. The variant is slower, and it affects young adults, and it's probably related to consumption of prion disease in the cattle. And in the cattle, it was called bovine spongiform encephalopathy. It can be also transmitted by blood transfusion or by corneal transplant. The clinical syndrome may cause rigidity and some Parkinson. For Parkinson, it is called the pill rolling. Pill rolling means like someone who is trying to count bills. So it's like doing this. There is diminished facial expression, stooped posture, slow voluntary movements, festinating gait, which festinating means that progressively shorter and accelerated steps. So finally, the person may fall because of these short and accelerated steps. The feet may not leave the ground enough to complete the steps. What is the difference between rigidity and spasticity? Rigidity is an extrapyramidal sign, and it is present in all range of movement. That's why it is called a lead pipe. It's like you are bending a lead pipe. While spasticity can be broken, it is called a clasp knife. The old knives that give resistance at the beginning when you try to close them, and then they snap into closure. So rigidity is different than spasticity, and of course spasticity is associated with hyperreflexia. It is a motor response that is Parkinsonism, not Parkinson disease, that is seen in a number of conditions, most commonly with psychotropic drugs, but also it's these diseases, and this is a common dysfunction in the nigrostriatal dopaminergic system, the tract that carries impulses from the substantia nigra in the midbrain and goes to the striatum, and striatum is the putamen and the caudate nucleus. That's called striatum. Parkinsonism may be induced by drugs, particularly dopamine antagonists such as phenothiazine, reserpine, and neuroleptics. Second most common neurodegenerative disease is Parkinson, again with age, atherosclerosis, drugs, head trauma, those who are who exercise in boxing and so on get hits on the head. And there is some sporadic and familiar forms for it because of a mutation in the synuclein. Synuclein is the protein that accumulates inside the cells in Parkinson's disease. The symptoms have the triad of tremor, rigidity, and bradykinesia. and it is the disturbance in dopaminergic pathway, and it progresses over 10 to 15 years. Eventually, it has severe motor slowing or immobility, and only 10 to 15% will develop dementia with advancing age. It may be idiopathic, and this is the most common form of it, and affects males more than females over 50 years of age. Single or repetitive head injury, such as what happened to this also very common figure. Progression of symptoms of akinesia, rigidity and tremor. We have to remember these three symptoms of Parkinson's disease that are necessary for the diagnosis. And then there are a list of other symptoms that we're going to show some of them. This is the appearance where there is difficulty with walking. There is masked face, such as what we see here for patients with Parkinson's disease. There is the positive reflexes, which is the glabellar reflex. If you tap with your fingers on the glabella, which is the area between the two eyebrows, then a normal reflex, a person will blink. And after 2 or 3 taps, the normal person can inhibit this and will stop blinking. A person with Parkinson's disease cannot inhibit this reflex and keeps on blinking. Palmomental reflex, you hold the hand of the patient and you scratch quickly on the lateral part of the palm, and then there is a little twitch at the ipsilateral chin, and this is called the palmomental reflex. Morphologically, we can see a normal midbrain with the substantia nigra. It's called substantia nigra because it has a black melanin dye within it. And a patient with Parkinson's disease, he loses the cells that contain the melanin, and therefore he loses the dark staining of that area. And this is the normal neurons in the substantia nigra filled with the melanin. And over here we have 2 things. We have less melanin and we have much less cells. So there is loss of the pigmented cells in the substantia nigra. How is it managed? It is very important, exercise and ambulation, to continue the patient to do their exercise, to help them with self-care, and to prevent injury. If they are falling frequently, they should be supplied with a walker to protect them, to pay attention to their nutrition and communication and support them. And then we give medications, but before we talk about medications, there is some surgical management that includes, in refractory cases, deep brain stimulation. Tardive dyskinesia is a syndrome that happens if one gives excessive dose of dopamine for the patient, and it may happen with patients who receive dopamine blocking agents such as phenothiazine or haloperidol. Definition is involuntary choreoathetoid movement. Choreoathetoid movements. Chorea is the fast movement, and athetoid is the rising movement. It affects the face, the mouth, the tongue, and the extremities, caused by treatment with neuroleptics, and it can be prevented by giving drug holidays and early recognition during a drug holiday and withdrawal of the offending drug. The treatment is to stop the offending drug and may increase acetylcholine with a drug called dianol, and reduce the catecholamine release with lithium or reserpine. The disorder can persist permanently after discontinuation of the offending drug, especially in psychiatric patients. Finally, we talk about motor neuron disease. It involves disease affecting selectively the voluntary muscles. It doesn't affect the involuntary muscles, causing atrophy and weakness. In the United States, they call it Lou Gehrig disease. Lou Gehrig is a baseball player who died at the age of 37 because of ALS. So his career as a baseball player was cut short. It is a progressive neuromuscular condition, combined upper and lower motor neuron signs. Fortunately, it's not very common. It's one or two in 100,000 population. Males are affected more than females. It is mostly sporadic, and in 5 to 10% it can be inherited, and the onset usually after the age of 40 years. And the clinical presentation, both upper and lower motor neuron signs, and with progression of the disease, there might be cachexia because the patient becomes very thin. But there is no sphincter or sexual disturbance, no cerebellar signs, no sensory changes or very minimal sensory changes, no cognitive changes, no oculomotor dysfunction, and no autonomic dysfunction. The pathology is loss of the motor neurons, and this is a motor neuron that has some inclusions. As we talked, if we see these things and you think they are pretty, they are not pretty. They are not supposed to be there. They are toxic. These called the Bunina bodies, and probably they are related to what was later on discovered as the TDP-43. ALS and frontotemporal dementia are related pathologically. They both are subtypes of FTD accumulation. We can see here the biopsy of the hippocampus that shows the accumulation of the FTD. This is immune staining for the FTD protein. And this is a lower motor neuron, anterior horn cell, in a patient with ALS that also was stained with the immune staining of the FTD. A proportion of ALS patients may develop cognitive deficit as an overlap between these two diseases. These are ubiquinated inclusions. We talked about at the beginning about the ubiquitin system. Ubiquitin system is a system that clears the old proteins from it just degrades them into peptides that will be turned as building blocks for new proteins. Motor neuron signs in 4 CNS lesions. In the brain stem, it may cause weakness or what we call bulbar weakness, and the patient may have a speech that is similar to the hot potato speech. It may affect the cervical, and they may get a neck drop. It may affect the thoracic, back and abdomen, and it may affect the lumbosacral. It causes weakness in the legs and drop foot. If there is upper motor neuron signs in the brainstem, it may cause clonic jaw, which is if you tap on the jaw, you get more than one response, one reflex. That's an exaggerated reflex. Clonic deep tendon reflexes, 3+ or 4+. Loss of superficial abdominal reflexes is an upper motor neuron sign. And lumbosacral region, you get clonic deep tendon reflexes, hyperreflexia. And you find the discrepancy between the preserved reflexes and weak or wasted muscles, or exaggerated reflexes and weak or wasted muscles. Diagnosis by electrophysiological studies that shows the combination of active denervation and chronic denervation. So both active and chronic denervation signs on EMG is typical for ALS. The prognosis is unfortunately guarded because most of patients die in 5 years. And if the onset is bulbar, there is worse prognosis because they aspirate and die. If there is a spinal onset, the longevity is a little higher. Short survival is associated with older age, lower vital capacity than the predicted for age and size of the person. There is a table for what is the predicted vital capacity. If we measure that for a person and find that it is low, that means he has very little respiratory reserve. And if there is short interval from onset to diagnosis, and if there is significant cachexia or weight loss. I think this is the last slide. If there are any questions. Any questions?
Doctor, they're asking in the chat.
I don't see any questions in the chat. Okay.
Doctor, there are a few questions in the chat.
Let me see. I can't find it.
So I can read them to you.
Okay, please.
So, Doctor, what is the difference between Parkinsonism and Parkinson's disease?
Okay. Parkinsonism is a symptom, while Parkinson's disease is a specific entity, specific pathology. Parkinsonism can happen if you give the patient haloperidol. They may develop symptoms like Parkinson, but this is irreversible. Parkinson's disease is a disease that is permanent.
Okay, the second question. What is the difference between rigidity and spasticity again?
Yeah, well, yeah, I explained that rigidity is present in all the range of movement. You hold the person's hand and you try to do this and this, and there is resistance in all the movement. That's why it is called lead pipe type. While spasticity, you try to resist, and there is resistance at the beginning, and then it breaks. So that's why it is called a clasp knife. It's like the knife that you try to fold, and then it resists at the beginning, and then it folds. Now I can see the chat. Why do patients terminate by pneumonia? Because they sit around, they don't move around, so there is accumulation of secretions. Can you differentiate between rigidity and spasticity? What's the difference between Parkinsonism and Parkinson's disease? We answered that. Drug holidays, taking break from drugs, yes. Yeah, patients who are chronically on psychotropic medications, such as dopamine blocking medication, phenothiazine, haloperidol, and so on. We try to give them every now and then a week without medications, and we try to see their response on clinical basis. If their psychiatric symptoms recur, we have to go back to the medication. If they don't recur, we may extend the drug holiday. On the other hand, if we stop the medications and they start having tardive dyskinesia, that means that we have to change the medication. The medication, if continued, it will worsen their tardive dyskinesia. Okay, I think we finished. We'll take about 2-3 minutes to stretch, and then we'll come back to talk about dizziness.